So thank you so much for giving me some of your time today. I'll talk a little bit about my experiences, particularly during the COVID pandemic. I was already working with mathematical modeling of infectious disease before the pandemic, but during it and after it, it became like a huge part of my research. So I'll just share a little bit about what kind of experiences I had, what things you can do with modeling, and what we can learn from it. As a quick introduction, I am Caroline Franco. As Dimitra said, I have been here in Aberdeen since June from last year. I am a lecturer in applied health sciences, part of the Aberdeen Centre for Health Data Science. And before that, I spent a few years in Oxford doing research and also teaching. And even before that, I did most of my training as a physicist in the São Paulo State University and the University of São Paulo. And even though I started as a physicist, I was always interested in interdisciplinary research, applied research, and throughout the years, I sort of got closer and closer to working with health issues, and I'm very happy to be able to contribute to public health and global health issues with the use of these mathematical tools. So in terms of the motivation for specifically for the things that I'm going to talk about today, at the beginning of the pandemic, many of us that had some knowledge about mathematical modeling, data science, and statistical models, we try to use those tools that we knew to better understand what was happening, to look at the data, find patterns. I remember when the first few cases were detected in Brazil and in other countries, we started looking at the data, trying to find if there was a pattern of exponential increase, the exponential growth, if we could calculate doubling times growth rates for the cases. Then this sort of effort became bigger and bigger. We started collaborating with some health and policy stakeholders and policymakers in a collaboration consortium, actually, that I'll talk a little bit more about later. That is the Observatório COVID-19 BR, which is this collaboration of academics in the whole of Brazil, all voluntarily doing research with very applied outputs to inform health policymakers, but also the media and the general population. And the idea is that we start with data, we start like looking for patterns, which we might start like using statistical models or simple exponential curves to understand the beginning of this exponential growth phase. But if you want to go further, if you wanted to explain more, if you want to talk about mechanisms of transmission and compare different intervention scenarios, different strategies, you need to do a little bit more than you can do with statistical models or data-driven models. So you need what we call mathematical models or compartmental models. So basically what we do is look at a problem in the real world, try to translate it into something in mathematical language that exists in the mathematical world. Of course, it would never be a perfect representation of what is in the real world, but the art of it is trying to extract what is essential, the essential mechanisms, so we can produce our outputs, interpret them, and feed it back to the real world with some meaningful interpretation and hopefully applications and maybe even be something that can use as evidence to better policy making. So the kind of tools and models that I'm talking about, probably many of you already heard about this SIR type models. Those are ones that basically you imagine your population of humans in a specific space as subdivided into susceptible, infected, recovered, and sometimes even more categories. It could be exposed individuals, vaccinated, not vaccinated, all this sort of things. Whatever is relevant for the disease or the dynamics you were thinking about. And this sort of models can reproduce this more intricate and nonlinear dynamic relationships between these variables. So instead of being able to only write an exponential increase of cases, you have this dynamics of peaks, of oscillations, or equilibriums. All these different types of dynamics come from these nonlinear interactions between these variables, and that can only be written if you know a little bit about the mechanism of transmission of the disease. So it's very important to know the underlying biology, the underlying behavior, the underlying interventions, and how they interact with everyone in that context. And this kind of model is useful more than prediction. Prediction and then forecasting is not necessarily the main part of it, because there might be lots of sources of uncertainties, but it is very useful in a context of comparing the impact of different intervention strategies. So, for example, during COVID, it could be different lockdown strategies, how long, when it starts, when it ends, are the schools open or closed, which percentage, what coverage of social distancing we are using. So we can compare the impact between like these different intervention packages. So this is sort of the tools that we used. And I'll talk a little bit about the different experiences, the different types of models that we produced during the COVID pandemic. So the first models and the first experiences that I had were in this context of the collaboration that I mentioned before, the Observatory, which is a Brazilian consortium of researchers that started with some people in my group and some other collaborators, my supervisor, and maybe like I think 2 or 3 other institutions. And then after a few months, we had like collaborators in all the states in Brazil, and everyone trying to produce not only using data and producing models, but also producing analyses or writing pieces that are scientifically based for the general population. Lots of interaction with media, so scientific journalists, for example. So it was very interesting. And also some interactions with health policymakers. So we had collaborations with stakeholders at municipality or state level sometimes that would use some of our analysis to help them make decisions. And another consortium that I was also part of was a broader international consortium that started with a group in Oxford, which I was already collaborating with. And we, our modeling group in Brazil started collaborating with this group in Oxford that also expanded, and we had collaborators in different countries. Some of them were modelers, data scientists, others were policymakers, health economists, and we all got together to develop this model that also had an interactive interface that we could use to sit down with a health policymaker, someone from the Ministry of Health of some country, go through the model parameters. What interventions do you want to explore in your country? What is the demographics? All the things that you needed to make a simulation, and they would say, what are the important intervention packages at the moment? They need to decide between this school health reopening strategy and this other one. So we would enter there and have a very participatory approach. Also, we had like this health stakeholders involved from the start in the development of the model. So there wasn't like one COVID model here, use it. that it was very dynamic. It changed in time. It had many versions depending on what they needed. And just to have an idea, it looked more or less like that, right? So it's a little bit more complicated than the first SIR model that I showed, but the principles are the same. We are thinking about what are the important groupings that we need to have in the population. For COVID, just having one group of infected people is not enough, is not representative enough. We need to think about the pre-symptomatics or the exposed individuals that might already be infectious, but not exactly have symptoms yet. We also need to think about severity of symptoms. So if they are asymptomatic, symptomatic, severe, do they need hospitalization? What kind of hospitalization needs they have? Do they get treated or not? Are there enough beds? So all of these things were in the model. And in all of these things, all these different categories, we came to that because of this cycle of participatory. We revealed the version, and then we talked to the stakeholders. People, it could be clinicians, it could be the health policymakers, and we would update and add the categories that were important and relevant for that context. And as I mentioned, we had like an interface where we could like in real time the model, updated, changes of some parameter, use a different intervention package and see what it looked like. And this is a model particularly that was used for, let's explore all these different types of intervention strategies, all these different combinations of lockdown, social distancing, mask wearing, working from home, all those sort of things. But that model was useful for that, for making this intervention scenario comparison. But we also worked on many other versions of COVID models, completely different, still COVID, but very different structures and very different results, because we wanted to also answer other questions. So we had the model that I showed that was sort of a more general model that could be adapted for different countries. You put like the demographics and contact rate patterns for a specific country and the interventions, and then you get a result. But for instance, we adapted it to make a Brazilian version. So it was like more specific in terms of how the health system worked, like the way hospital beds are classified might be different from country to country. So making one general model sometimes would be a little bit difficult to even read the data and use the data that you have in the country. There was something like, having ventilators or not. In some countries, you would keep track of it, but we saw that in Brazil, everything was called ICU beds. They might have ventilators most of the time, but then you don't exactly have data for that. So the model also depends on the kind of data you have available. So we made a version including what made sense for that context, and also some other tweaks that I'll talk about in a little bit. And we also adapted in the sense of some behavioral patterns that were only seen in that country. So like some we had some more difficulty calibrating the model, so fitting the model to real data in that context, because behavior culture is different. So the way the non-pharmaceutical social distancing interventions were affecting the population was different from some other countries. So that needed to be taken into account. Another type of model that we use, also COVID, but we had to split the model in different sort of two different levels for different strains, was when the question of what is the transmissibility of different variants of concern are also brought right at the beginning. I think one of the the variants of concern was really aggressive, really fast, really severe, and produced a lot of a great impact in the north of Brazil. So that was a very hot questions, and we used a model to using the data from zero prevalence studies. We were able to estimate the transmissibility of one of parameters of our model. Other kind of study is vaccine delivery strategies. So we produce even a different model now, adding vaccination sort of levels. So if you had like different doses of the vaccine, that was taken into account in the model, and also like how fast the vaccines were produced, how fast they were delivered, and all these things as a framework to try to understand what would be the optimal strategy depending on characteristics of the vaccine and characteristics of the logistics of production and delivery. So a different model for that. Also, another one was about comparing quarantine, testing, and school reopening strategies. So we had to add extra layers to explore these interventions in the model. So, and we would explore, for example, different levels of coverages of these interventions and how they affect different age groups. That was another one. And finally, the most recent one that I worked on, I think it was 2022-23, was a commission by the UK Health Security Agency that was trying to evaluate the impact of the testing program that they had in England. So basically, the idea here was to produce a tool where you would take into account the variability of viral load for different individuals at different age groups, and all types of strategies of testing and isolation, and which one would be more efficient in terms of impact in the forward transmission, or in terms of like is it efficient to keep us people isolated for that long, in terms of like how absent they are going to be from work. So taking all these things into account, so we sort of defined some metrics to be able to compare the different strategies. Coming back to the COVID model, something that I wanted to mention is that other than this different categories that we had to add to the model that I mentioned, susceptibles, infected, exposed, etc. For COVID particularly, it was very important to add in our baseline model the effect of different age groups. So it was very clear from the beginning that COVID had a very different impact for different ages. So as, of course, for elderly individuals, it would happen, the severity or the infection fatality rate could be much higher. And that needed to be taken into account. So we use demographics in terms of population age distribution that can be very different for different countries, and also contact patterns data. So basically, we had this matrices that came from a very famous study by Prem initially, I think, published in the 2000 and something, and then they produced a new version in 2020. So this data has contact rates, so number of contacts per day between different age groups for different countries and at different settings, at school, at home, other settings, and work. And we use all of that information to simulate how people from different ages were basically getting exposed to the possibility of transmission. So each of the compartments that you see here in this diagram is actually multiplied by 10 or 20, depending on the number of age categories that you have for a specific country. And for this specific model, like I mentioned, it was very important to include the effect of non-pharmaceutical interventions, and that is done by looking at data, for example, from the Google mobility reports or transport data to understand how much people were going to work, staying at home, going to parks, and all of this influenced the calculation on the rate, the contact rates, that instead of being that matrix was now modified by these proxies that could be were actually proxies for the coverage of certain interventions. And that all impacts what we call the force of infection, which is the rate of transmission of the disease. So the rate of an individual going from susceptibles to the exposed compartment. Another thing that we added that I mentioned before is that this percolation approximation that was very important in the Brazilian context. We noticed that trying to fit and use this model in the Brazilian context was a bit more difficult that compared to other countries. And we thought that maybe it's something about the underlying contact network that is there. Of course, that we had already incorporated the heterogeneity in terms of age that comes with the symptomatic presentation of COVID. But we thought that maybe we are missing something else. We are missing the heterogeneity in contact patterns that is always there, already exists. So not all of us have the same contact rates as everyone else with different age groups. But more than that, when you start breaking some of this, some of the connections between people or between households with non-pharmaceutical interventions such as social distancing, working from home, and lockdowns, that changes a lot the underlying network of connections of a population. So that was also an important thing that we explored in one of our models. We use network theory to try to come up with a simple sort of way to model the how these connections were changing drastically when you increase the coverage of these interventions, and that led to better agreement of model simulations and data that we had. Basically, the idea was to come up with a mathematical formulation that would represent that phenomenon that we thought we were observing, and that was plugged back into the contact matrices calculations for, in this case, for home contact matrices. So we were modeling how the number of contacts within households was changing due to all these other interventions. And it's also very interesting how this impacts the basic reproduction number. Basic reproduction number is something that was, I think, talked a lot during the pandemic, which is this magic number that sort of represents how a disease is spread within a population. The thing that is not talked about so much is that the basic reproduction number is not one number for each disease. It actually depends on the population you're talking about. So you have a different R0 for a different populations with different underlying networks of contacts depending on how the transmission happens. And we also saw that influenced a lot also this basic reproduction number depending on the contact network that we were considering, with or without this approximation that we were proposing. And I'm talking about it because this is one of the things that we struggled with, but we came up with like new ways to do this modeling to bridge the gap between something that is more like a individual or household level approach to this population level effect. And that is sort of also bridges the gap between this and the next session. So the idea is that we learned from it. We learned that there are still some things that we need to improve in our models. So methodology might need to be further developed. We have these tools already. So one of the ideas, one of the things that I have been slowly working on is to find better ways to translate this individual level effects due to heterogeneity that can be more than contact heterogeneity. It could be heterogeneity in susceptibility patterns or incubation rate patterns, how you can translate that thing that happens at an individual level to a population level model in a simple enough way so you can use and implement it timely when there is a need. So that's one of the things that I think is a very interesting area to work on in terms of developing better methods and in terms of preparedness. So there are many levels, many things that are part of preparedness, and I think having better tools to tackle emergent diseases, better models that we can more readily use them with confidence might be an important part of it. And of course, always doing that participatorily and involving anyone that should have a say from clinicians and modelers and all important stakeholders. Another thing that I've also been working on is the idea of multi-species or syndemic modeling. So in our collaborations with the local NHS, this is something that came as a potential interesting and important project, thinking about like how all these different diseases are common causes of cold and flu, and especially during winter, might interact, and how can we address them together with more integrated strategies. So one of the ideas is to think about integrated immunization strategies. Are there ways to perhaps not only look at all these diseases separately or the vaccination strategies separately, but actually think about them together, how they are interacting with each other in terms of not only biological interactions, but systemic interactions and like how we deliver certain interventions. So that's one of the things I'm also working on. And and this is happening in the context of the very good environment that we have here, having the Center for Health Data Science and having lots of collaboration with NHS stakeholders. Particularly, we have started this group on dynamic modeling of healthcare, which is an initiative that started with Corey last year with an initial meeting, and then Dimitra and myself are now organizing some more or less regular workshops. And the idea is to bring together whoever can contribute in any modeling projects going forward. Not only modelers, not only NHS stakeholders, but we even have artists in the group, people from computer science, physics, and other departments. And the idea is to be very interdisciplinary, very open, and also improve our communication amongst ourselves. So yeah, if anyone is interested, you can just reach out to one of us to talk about these things or join the workshops. If anyone has any questions, please feel free.